Hello and welcome everyone. We're happy to have you joined us today for our webinar, The Future of Pulp Preservation and Restoration, Unlocking Biodentine's Full Potential. During this session, we will have deep dive into the use of biodentine in the biobulk fill procedure for effective pulp preservation and tooth restoration at the same time. This lecture will feature an incredible speaker, Dr. Kreena Patel. Dr. Patel has been using Biodentine for about 10 years and will be sharing her valuable insights, case studies, and tips on how to use Biodentine to its full potential for successful results. I now invite Dr. Kreena Patel to introduce herself.
Thanks, Anna. So my name's Kreena. I'm a specialist in endodontics. I graduated from the University of Manchester, and following that, I did some work in general practice and also some hospital posts in children's dentistry, oral surgery, and restorative dentistry. After that, I went and did my endo speciality training, which I did at King's College London. And following this, I stayed on to teach on the programme for about 4 or 5 years, as well as going into private practice. And really, my true self is I'm a clinician. I enjoy the clinical aspect of endodontics, so that's what I do the most. I work in the UK, both in South London and in Reading. And I also do some teaching, so I have my own online course and hands-on course, and then I enjoy lecturing as well. So it's lovely to meet you all, and thank you all for joining us tonight.
Thank you very much. Before we begin the webinar presentation, we'd like to learn more about our audience. This will help us understand who we are presenting to and allow Dr. Kreena Patel to tailor her responses during Q&A session. So I will now launch a quick 2-question poll. Normally you see it on your screen. The first question we'd like to ask is about your dental specialty, as you can see. So are you a general practitioner or an endodontist, or do you belong to another specialty? Okay. I see that the responses are coming in. I'll wait it for a few more seconds. Okay, now I'll share the results with you. Can you see the results, Dr. Patel?
I can't. Oh, there we go. Yes, I can. Yeah,
Okay.
and we see a nice mix, I think. And as I expected, there's a lot of general dentists here, which I think would be good because we're going to focus a lot on, direct pulp caps, indirect pulp caps, and pulpotomies. But it's really nice to see there's a mix of specialities there.
Super. Thank you. Now I'll launch the second poll. Okay. You should see it on your screen now. So this time we'd like to understand how you currently use Biodentine, or if you're not using it yet. We're interested really in learning more about your experience with the product. So just like before, I see that many of you are already responding. I'll wait a few more seconds to make sure everyone has a chance to answer. Okay. Do you see the results now?
I do, yeah. So it's interesting to see that not many people are using it at the moment. So hopefully this webinar will be, eye-opening for the ones not using it. And I can see that most people who do use it are using it as a layer technique, which is very much how I used to use it. But now I use it in the biobulk fill technique, and that sort of changed very much in the last couple of years. So hopefully this will show you why I use it in the biobulk fill manner compared to a layer now.
Super. So we're about to begin the webinar. Just so you know, Dr. Kreena Patel's presentation was pre-recorded to avoid any potential connection issues. We'll now play it for you in full, and at the end of the session, we'll meet here again to answer your questions and ensure you leave with a deep understanding of the topic. If you have any questions, please don't hesitate to share them using the question box, usually located on the right side of your screen. Feel free to submit your questions at any time during the presentation. We'll do our best to answer as many of them as possible at the end of the session. Now we are going to turn off our cameras and mute ourselves as we begin the presentation. We'll be back in about 45 minutes to answer your questions. So sit back, enjoy this great lecture, and we'll see you here shortly.
Welcome everyone to this webinar on the future of pulp preservation and exploring Biodentine's full potential. So to start with, I'm going to be talking about current guidance on avoiding pulp exposure. We know that it's better to try and avoid pulpal trauma, and therefore if we can avoid exposure, that's always best. I'm also going to be talking about Biodentine XP. That was launched in 2023, and what's new about that material compared to the old material. I'll be talking a little bit about the advantages of using material like Biodentine. And also, I've been using this material for about 10 years or so now. So I'm going to go through my progression and how I used to use it and how that's quite significantly changed. And now how I'm using the BioBulk fill procedure. I'm also going to be talking a little bit about how we place a definitive restoration on the Biodentine afterwards and the bonding protocol for composite. I tend to learn best when I look at my own cases, so when I analyze them afterwards, and also when I look at other people's cases. So this presentation is going to be quite case heavy, and I'm going to be going through direct pulp caps, indirect pulp caps, partial and full pulpotomies, and my progression on how I used to use the material and how I now use it for these sorts of cases. So let's start. This is a radiograph of a lower 7, here you can see. It's got quite extensive recurrent caries, and you can see that it's approaching the distal pulp horn here. That pulp horn has retreated and laid down a dentine bridge, and we would hope that it would do that because it's a positive reaction, that it's sort of walling itself off away from the caries. Now, this patient presented with pain with sweet things and with cold things that lasted a couple of seconds. She had no long-lasting pain, no pain with hot, no spontaneous pain. So we've diagnosed reversible pulpitis for this case. And in all cases of reversible pulpitis, ideally we should try and preserve the pulp. However, we are turning a clinical set of symptoms into a histological diagnosis, aren't we? So we are just taking that and assuming we know what's going on in the pulp. But is there any correlation? Well, this is a really good study that was carried out. They looked at 95 teeth and they, again, listened to the patient's symptoms, and from them, they got a clinical diagnosis. They then extracted the teeth and then histologically analyzed the pulp. How well did it correlate? Well, if the patient complained of reversible pulpitis, 96.6% of the time, that was what they found was going on in the pulp. That pulp was in a state of reversible pulpitis and it could repair itself. If the patient complained of irreversible side symptoms, it was still, again, very well correlated, slightly less so at 84.4%. And that means that whatever our patient tells us, very likely this is what's going on. So with all of these cases, let's try and avoid pulp exposure. This is a fantastic document that was published some time ago in 2019, and it's the ESE position statement on how we should manage deep caries and the exposed pulp. And they talk about selective caries removal. Now, selective caries removal is where we completely remove caries around the cemento-enamel junction, but we can leave some caries over the pulp in order to avoid a pulp exposure. Now, there are different types of dentine that they talk about. One is soft dentine. So this is caries that can be excavated with minimal resistance from a hand instrument. Then there's firm dentine. Firm dentine is where we can remove it, but it's quite resistant to hand instruments. And then there's hard dentine, and this is completely sound, resistant to probe penetration, gives that scratchy sound when we sort of scrape it with a probe. So around the CEJ, we need to get to hard dentine. So a really nice layer of dentine that we can then bond to and form a really good seal from the external aspect. but over the pulp, we can leave soft or firm dentine. Now, I tend to try and go to firm dentine and not leave soft dentine if possible. But there is a lot of evidence now that you can leave soft dentine behind. And you can treat these cases in one stage, so place a definitive restoration straight away. Or if you have left soft caries over the pulp, you can do stepwise excavation. And what that means is you go ahead, you seal it very well, then you come back 6 to 12 months later, you remove the soft dentine over the pulp down to firm dentine, and then place a new definitive restoration. And what is our aim? Our aim is to form a dentine bridge. So you can see here, this is the pulp, and this is our capping cement and permanent filling. And we're aiming to get this little dentine bridge formed between our capping cement. And there are two types of dentine bridge that can be formed. The first is reactionary dentine, and this is formed by odontoblasts that already exist around the pulp, and they're primary odontoblasts. If more of the pulp is damaged, some of those primary odontoblasts become necrotic, they die, but new odontoblasts can be recruited from the pulp. So we know that there are stem cells within the pulp and they can be recruited, differentiated, and they can lay down reparative dentine. It's not as ordered as reactionary dentine, but the tooth then still has the ability to survive, and that pulp can survive. So, does the material matter that we use? Well, in my opinion, I think it matters a lot, and there's a lot of evidence again that surrounds this. So, as most of you know, I use Biodentine for all my pulp capping. And the reason is it's a fantastic material. It's very kind to the pulp. During its manufacture, it's got a really high purity. It's made with very strict quality control. There's no illuminates, no sulfates in it. So very kind to the pulp. And also it doesn't contain resin. Now we know that resin can cause inflammation of the pulp and damage to the pulp. And therefore the dentine bridge that can be laid down can be quite damaged or non-existent. So this is quite a nice graph. And what we're looking at on this graph is cell viability on the long axis, and then different materials down here. The blue color is 24 hours, the red is 48 hours, and the green is 72 hours after the material has touched the pulp cells. So we can see here with dical, we have very good cell viability. This is a setting calcium hydroxide. If we move over here, there is theracal. This has a resin in it. So the benefit of having resin in a pulp capping agent is that it's easy to handle. So you pop the pulp capping agent there, you cure it, and then you can move on and do your final restoration. But we talked about how much damage resin can do to the actual pulp. So in an ideal world, we don't want that sort of material there. On top of that, when you cure with a light cure, you produce heat, and that can cause pulp damage, and you get some polymerization shrinkage as well, which is not ideal. So then moving on, we have MTA-based materials here, and you can see we have very good cell viability with that, as we would expect, but it looks like it can deteriorate with time. And then this final material here is Biodentine, which shows that we have really good cell viability over the time period. Biodentine is also antibacterial, which is what we want when we're placing a material close to the pulp and where there's been caries and obviously bacteria as a result of that. And it maintains a high pH over 11 for over 28 days, which is great. It also is not just biocompatible to the pulp, it's also bioactive, and it can induce positive changes. It's anti-inflammatory, which is really good because obviously we know that the pulp is usually in an inflamed state. And it also initiates mineralization. So we get a stimulation of growth factors, particularly TGF-beta1, which helps with odontoblast recruitment and differentiation, as I mentioned before. And these are histological slides, and you can see here, this is MTA that's been placed. So this is the pulp. The arrow is the dentine bridge that's formed. So we do have a nice dentine bridge with MTA. With Biodentine, you can see that the dentine bridge is more dense and more homogeneous. And this is a material that contains resin. So this is a theracal capping agent. And you can see that's not what we want to see from a dentine bridge compared to the others. The other good thing about Biodentine is it bonds to dentine. So when it's first placed, Biodentine sets over about 12 minutes, and that's its initial set. At that stage, we don't have a good bond to dentine, so you have to be quite careful not to dislodge the material during that phase. However, long term, we have this mineral infiltration zone that develops. So this was a lovely image that was sent to me by Prof. Amra Atma, and he's done a lot of research in terms of the bond between biodentine and dentine. So you can see up here, this green layer here is the biodentine. Down here is the dentine, and you can see the dentinal tubules that we see here. And this material here is where the biodentine and dentine have interacted, and we get this mineral infiltration zone, which helps it bond together. So it's like ion exchange. Also, we can see that the biodentine aspects have the mineral deposits have gone into the tubules, and we get these sort of tags or crystals that form within the tubules to give a really good long-term bond. The other thing about biodentine, as I mentioned, is it doesn't contain resin, so we don't cure it with a light cure and then get that polymerization shrinkage. So it's also really dimensionally stable, which helps again with the seal. So one of the reasons that I like biodentine more than MTA is the setting time. So biodentine's initial set is 12 minutes, and after that you can then restore the tooth definitively, although we'll talk about the different ways of restoration. So something like MTA takes about 70 minutes to set, which is a long time. And then that's that initial set time. It takes longer to definitively set, as does biodentine. And that's because biodentine has an accelerator in it, which means that it sets quicker. The other big advantage over something like MTA is it doesn't discolor the tooth. So you can use it for pulp capping or anything in anterior teeth, whereas with MTA, you will get a long-term dark blue-black discoloration of the tooth. So this is a little picture of a sandwich, and it's exactly how I used to use biodentine, but don't anymore. So let me show you some cases of this. So this is a video in a second of me restoring this lower left 7. We can see there's fairly extensive caries, and it's approaching the pulp. So if we go in, first thing that I do is place a rubber dam on the tooth. So a rubber dam is really important when working in this sort of situation, because you don't want the patient's saliva to get anywhere close to the pulp because it contains bacteria. So if you inadvertently cause a pulp exposure, if you have a rubber dam on, it's much better. And also we want the final restoration to have a good seal. Here I'm using a large rose head to remove the caries first around the cemento enamel junction. Don't use a small rose head because you can penetrate it too far and quickly cause an exposure. Here you can see I've left firm dentine over the pulp. It's resistant to excavation with a excavator, but we've got very sound dentine all around the cemento enamel junction. So this is what you want to aim for. You can see I'm feeling it here. The next thing I'm going to do is place biodentine over the pulp. Before I do that, I've just got some cotton wool and some hypochlorite and cleaned that area really well. Because I've left a little bit of caries you can see over the pulp, I don't want that to have any bacteria in it, or as little bacteria as possible. So this is the biodentine. This was the old biodentine, and you can see I've tried to be very neat with it. I've put it right into the center. And I'm not putting pressure here with the amalgam plugger, I'm just gently spreading it so it forms a homogeneous mass. And this is the next bit going in. And this bit is quite fiddly with the old one, trying to get it very neat and tidy, picking it up with an amalgam plugger and then trying to get it into the cavity. So this has changed a lot with the new XP, which I'll show you in a bit. So once this layer was in, and you can see it's a fairly thin layer I've used, I then put a composite restoration on top. So this again has changed with the way I use biodentine now, as I'm going to show you. I would have now put in a much thicker layer. And the way that I put my composite in has changed as well. So after 12 minutes, it's set and it's done its initial set. Now I'm going to put composite on top. And you can see here, I used to etch and bond the dentine and the enamel, but naturally it would fall on my biodentine. But again, we know now that if we're restoring teeth in a single visit, ideally we don't want to etch the biodentine. So we'll talk about that and the new protocol in a second. So let's talk about what's new. The first thing is the Biodentine XP. So previously you would have a capsule of biodentine and you would need to add the liquid accelerator and mix it in your own machine. Now we have an all-in-one cartridge So we have two different sizes. One is the 200 milligrams and the second is the 500 milligrams. I quite like having two different capsule sizes because it means I'm not wasting material if I'm using Biodentine in a single visit. And I know that if I needed more, I've got more in the bigger capsule size. It's mixed with its own mixer, and then it's put into the Biodentine gun, as you can see on the bottom here, and then you can dispense that directly into the cavity. And you can also bend the tip of the Biodentine capsules with a sort of 90-degree edge. So you can dispense it literally very easily into that cavity. So you've not got the faff of trying to pick it up and put it into the right place. It literally goes in very, very nicely. And the big differences I've noticed is now we get a consistent mix. Before I felt that most of the time my Biodentine would mix well, but sometimes I would get a harder mix, sometimes a softer mix. With this one, it's very consistent and it's very nice. It also has superior handling. Like I feel I can use it in a much more quicker and predictable fashion. So let's look at this case together. Again, this is one of the ones that I treated many years ago, and I've changed the way that I use the material since then. So it's for your sort of vision on how we used to do it and why it's easier now. So you can see this lowest 7 again has extensive recurrent caries. It's fairly close to pulp as well. So first thing I do is pop a rubber dam on and remove caries. And this is after I've done that. Now I was very careful over this area here because I knew it was close to the distal pulp horn. However, I didn't anticipate how high the mesial pulp horn was, and I did end up with a small exposure here. So that was initially bleeding. The first thing I did was think, okay, let's do a direct pulp cap. So I tried to stop the bleeding. And the way I do that is I get a sterile cotton pledget. I pop sodium hypochlorite on it and I squeeze all the hypochlorite out. So now I'm left with just a very damp pledget. I pop that over the exposure and leave it there for 2 minutes. And then I take that off and have a look if I've got hemostasis. A healthy pulp should stop bleeding in under 5 minutes. Usually I find within 2 minutes it has stopped, but 5 minutes is the cutoff really. It did in this case, as you can see. So I put a very thin layer of Biodentine over that area there. And you can see I've made it a little bit messy, which used to happen with the old Biodentine and placing it with an amalgam plugger. So I've got these sort of little shards of Biodentine there. After the 12 minutes, once that's set, I would use a probe just to remove these edge bits, or sometimes a very small rose head in a slow handpiece, and again, just gently remove those bits. And then I would put a resin modified GIC layer on top, followed by a composite restoration. Now, for this case, it went very well. You can see here, pre-op and post-op, the patient was asymptomatic at the review, and I got a positive sensibility test. So a method like this works, but it is very stressful as a clinician. I'll tell you why. So firstly, when I'm removing these little bits here, the Biodentine hasn't fully set, so it hasn't done its long-term set, so it hasn't bonded to the Biodentine well at this stage. And what can end up happening is the whole Biodentine section can come off, and then you're starting from scratch again. So that's one problem. The second is when I'm putting the resin modified GIC on top, you can see again, that's very fiddly as well, just trying to get it over that area there, bonding around the Biodentine. I was never quite sure of my bond with my GIC to my Biodentine. I felt like, we were trying to bond, but nothing was extremely well sealed. So I didn't like having to use another material on top of the composite. So these were the things that bothered me. And I was using it very much like a capping material like MTA or like calcium hydroxide. However, Biodentine has much better properties. So it has physiomechanical properties close to dentine. So you can see on these charts, this is MTA, GIC, dentine, and Biodentine. We have very similar compressive strength to Biodentine to dentine. Same for hardness and same for flexural strength. So we should be making use of these properties. So what we can now do is do things in the bio bulk fill procedure. And that means using a much thicker layer of Biodentine and using it as a restorative material, not just as a pulp capping material. So we can do this in 2 stages. I would say the two-stage procedure is the easiest way to use Biodentine. And if you don't mind treating that patient over 2 visits, then this is probably the easiest way to do it. So the first thing you do is fill the entire cavity from pulp to tooth surface with Biodentine, send the patient away after its 12-minute set, and then 2 weeks to 6 months later, they come back, you cut back the Biodentine and place a 2 to 3 millimeter composite layer on the top of it. And that's because Biodentine doesn't have very good wear resistance. So you do need to get them back to definitively restore the tooth, but it can last for quite a significant amount of time. And that then gives you time to analyze, how's that patient doing? Are they having any symptoms? So it gives you that flexibility. However, if you're like me, I quite like to get things done in one visit. So I usually go for the one-stage procedure. That means that you use Biodentine in a much thicker section. So you use it to replace the dentine portion of the tooth. So not like the thin layer that you saw me just do, but a bigger, thicker layer. And then you leave 2 to 3 millimeters of space on top. And once the 12-minute set has done, you then place that composite layer straight away. Now, if you're doing it in these ways, we need to know how to restore the tooth with composite afterwards. So what is our composite bonding protocol? So if you're doing it in 2 stages, you've left the Biodentine for a while, like we talked about, and you've come back. At that point, you're removing your Biodentine, and you can do any etching procedure you want now over that Biodentine. So you can etch it, or you can choose selective etch or a self-etching procedure, and then you bond the composite on straight after that. The only difference comes is when you're doing a one-stage procedure, and that's because we need to protect the Biodentine during its initial set. So this way, you've waited your 12 minutes, your Biodentine's in. You then do self-etching adhesive over the Biodentine. So I use something like Scotch Bond, place it over the Biodentine, and then put a layer of composite on top of that. However, with your enamel and your dentine, you can do any sort of etching procedure you want with that. So you can etch it with normal etch or selective etch or self-etch, and then put your composite on top. It's just over the freshly set Biodentine that you need to be careful and only use a self-etching adhesive. So why does this work well? Well, for me, I feel like I'm using fewer materials. So I'm cutting out GIC or resin modified GIC. And this means that we've got fewer clinical stages, which means less time and less scope for any clinical errors to happen. Because the more stages we do, the more little errors that can happen. I also feel like we've got better surface area for bonding. So firstly, for the Biodentine, because we're bonding to a bigger surface area for that. And then we've left enough surface area for our composite bonding to seal really well on the external aspect as well. I also feel like I've now got a thick layer of the Biodentine in the critical area, so over the pulp. And we are less likely to disturb that when putting the coronal composite on. So in the case I just showed you, you could see that I had a very thin layer of Biodentine, and then I put a resin modified GIC on top. And I'm not that happy about that because I don't want a resin-based material near the pulp. And so we've taken that area out. We've now got a really thick layer. And if I do a single visit procedure and I put a composite on top, I'm not doing anything close to where it's very critical near the pulp. So let's look at a more complex case. This lower left 7, you can see, has extensive recurrent caries. And this time we've got a missing marginal ridge. So the first thing to do is pop a rubber dam on and caries removal. You can see that the cemento enamel junction is completely clean, and we've got no breach into the pulp, but it's very, very close. I pop a sectional matrix band on, and the first thing I do, if I'm not going to do this in 2 visits, if it's a 2-visit procedure, this is very easy, right? You put Biodentine in and then send the patient away and come back and restore it at a second visit. But if we're doing it in a single visit, that's when these things become tricky. So I put a sectional matrix on, and the first thing I'll do is etch, bond, and place a composite onto the marginal ridge. So I'm turning this into a cavity with 4 walls. So that's now the outer composite ridge placed. And then it's very easy at this stage just to inject the Biodentine into the middle bit where it's important, where the pulp is, and use it as an indirect pulp cap. Once that's then set, I'm putting self-etching adhesive over the biodentine, like we talked about, and a layer of composite. And then I tend to etch and bond everything and put an occlusal composite in. So that's how I tend to do things. I've actually modified the way I do things a little bit more since this procedure. You can see here that I had full sort of caries removal before I built the marginal ridge up. The problem with doing that is I could have caused an exposure, and then I would have had a real problem building that outer marginal ridge up again because of that exposure. So what I tend to do now is remove all caries around the cemental enamel junction. Don't go anywhere near the pulpal area. Build that ridge up first, and then carry on with my caries removal over the pulp. And that way, if I end up with an exposure, it's already a full-walled cavity, and I'm not having to do that delicate etch bond step in between. Let's move on and talk about a partial pulpotomy. So this was a really interesting patient I saw. He was a 25-year-old gentleman, and he'd seen his general dentist for caries removal on this upper molar. During caries removal, there was a pulp exposure. So his general dentist placed a cotton pledget with hypercal over the pulp and then a temporary restoration and sent him to me for root canal treatment. By the time I saw him, it was 2 to 3 weeks later, and he had symptoms of reversible pulpitis. Now you can see that this tooth looks extremely abnormal, and it's a very interesting tooth. It has gemination, or it's a double tooth. Now this is where one tooth bud attempts to divide, and we get two partially or fully separated crowns, but they share a common root canal system. When you have a look at these patients, their tooth count is completely normal when this anomalous or odd tooth is counted as one. It's different from fusion because fusion is where you have two tooth buds that come together. So that sort of patient will have less, one tooth less in their mouth compared to someone with gemination. And in an ideal situation, we want to avoid root canal treatment on a patient like this. If we have a look at the cone beam CT, they had a completely normal periodontal ligament space apically around the roots, and the lamina dura was intact. And you can see with this fused root canal system, they had 8 canals. So trying to do a root canal on this tooth would be quite destructive and quite complex. I was keen, if we could, to try and preserve the tooth, preserve the pulp. Although I was very aware it had been a long time since the pulp exposure. So first thing I did was rubber down, and I removed the temporary filling and caries, the remaining caries, and you can see here. Now the pulp was hyperemic, as you can see. I was keen to treat this in one visit if I could, because the patient had come from quite a long distance. But in this case, you can see it's very complex because I'm going to try and now build up my external wall, having had an exposure of the pulp. Now, fortunately, the pulp here stopped bleeding, so I etched and bonded the wall and placed a composite restoration. I then did a pulpotomy. So I took 2 millimeters off the pulp, and you can see I've used a high-speed handpiece with a diamond burr. And these are the sort of diamond burrs that I prefer. They're red banded burrs. So in this case, I probably used a tapered burr just to remove the pulp. And this was after I built the composite wall. So of course, this is not ideal. One situation that could have happened is the pulp might not have stopped bleeding enough for me to do this. And the second thing is, obviously, as I'm washing this etch off, it is getting into the pulpal area. The reason I chose to do this is because I knew I was going to do a pulpotomy on this case anyway, because it had been exposed for so long. So once the composite wall went in, I then placed Biodentine. And you can see here, it's again another mistake I made. I put too much Biodentine in. And so after the 12-minute set, I had to very gently cut this back a couple of millimeters to put my coronal composite in. Try not to do this because that initial set is very difficult. You don't want to disturb the material too much. But we had a very successful result. So this was preoperative, post-operative, and this was at the review. It was positive sensibility testing, and the patient was asymptomatic. I saw him a year down the road as well, and again, he's asymptomatic at that review as well. So it's really pushing the material to its limits at this sort of in this sort of case. But I wanted to show you so you can see the mistakes I made and how I've learned from it. Now, there are some barriers to use in terms of using Biodentine. So here are my sort of tips to use it over the years that I've built up. So the first barrier to use is the cost of the material. Of course, there is an expense to the material. And the way I overcome this is I talk to my patients about the benefits of using it. I tell them that I feel like it's the best chance for the pulp to survive. And quite often, especially now, most patients, who are more educated, they're keen to try and preserve and be more conservative with their treatment. As a clinician, you do need to build that into your fee. Otherwise, you'll feel like you don't want to use this material. So I always charge an extra fee to use it, and that includes the time that it's going to take to use it as well. And then you will feel more comfortable in terms of its use. The other barrier to its use is its setting time. It is very long. So 12 minutes feels like a long time. However, I think you need to overcome this in different ways. The first is talking to your patient about it. So I always warn them at the consultation, and when I'm describing sort of this is the plan that we're going to go down, I always tell them that there is this setting time that they need to be aware of. When I've used the material, I've always tried to put a well-sealed rubber dam on. So then I partially sit them up during this setting time so that they're more comfortable. I will also tell them to bring some headphones so they can listen to music or a podcast or something when this is happening. So I do obviously keep an eye on them, but I make sure that they're nice and relaxed during this time. Now, me as a clinician, I think my work, I'm very fast. I find it difficult to sort of sit and do nothing for a length of time. So I actually set an audible alarm on my watch or on my phone or my computer. And I tell the patient, listen, there is this alarm that I've set. Do not let me touch it before this 12 minutes because I'm not meant to and I always want to. So I feel like we're in it together. Often I'm doing something and then I come back at about 10 minutes. I tend to get a bit, let me have a little check. And you see the patient going, no, Kreena, your alarm hasn't gone off yet. So you're in it together, which is quite nice. Also make use of your time. So you have this time, do your notes, make sure your nurse knows that you're waiting for this material to set, and she can start tidying up or do whatever that she needs to do as well. So obviously you want to keep looking at it to make sure there's no leakage of your rubber dam and things like that, but you have time to sort of make it pass a little bit faster. So let's move on and look at another case. This was an 8-year-old boy who I saw very recently, actually. He had trauma 24 hours prior to me seeing him, and he'd seen his dentist on the same day and he'd been referred to me. Fortunately, I could see him fairly soon. So he had a complicated enamel dentine fracture of the lower right one and the lower left one. And he also had luxation of the lower left too, and that was grade 1 mobile. And you can see on the radiograph, we've got incomplete root development of these teeth and quite significant fractures. So what do we do? How do we treat this? Well, the first thing is anesthetic. So I gave him a buccal infiltration and an intrapapillary to numb the lingual aspect of the tooth. I then isolated the teeth. This was quite difficult because I couldn't clamp the lower left too, which had a luxation injury, of course. So this is a Brinker clamp that I've used. They're very good. They can help grip the tooth a little bit better than some anterior clamps. Next thing to do is remove 2 to 3 millimeters of pulp tissue. We know that this pulp has been exposed for more than 24 hours, and we're likely going to have some irreversible inflammation because of that exposure. So I used a fast handpiece and a sterile diamond burr to remove that pulp tissue. I then used a sterile pellet with sodium hypochlorite. Again, as I described, I place it in hypochlorite and then I squeeze the majority of it out, so it's just very damp when I'm using it over the pulp. And we see if we can get hemostasis within 5 minutes. So you can see on the lower left one, we managed to get good hemostasis. It's not bleeding through the pellet. But on the lower left two, we've still got a hyperemic pulp. It's not stopping bleeding. So what do? That means it's inflamed. We want to remove a little bit more. So I removed a little bit more. And then again, repeat. Back with the sodium hypochlorite and the pellet and see if it stops bleeding. And this time we've reached healthy pulp tissue. Next thing I did was put Biodentine over the pulp exposure and waited for 12 minutes. I then used the self-etching adhesive over the Biodentine and popped a little bit of flowable composite over that. And then I etched, bonded, and did a composite build-up for him. He reported he had less post-op pain the next day compared to what he had before. His main symptoms were when he touched the teeth with his tongue, or there was something cold, he was getting pain. So everything was reversible pulpitic in terms of the symptoms he had. And he was completely asymptomatic within 24 hours, which was great. I actually wanted to see him for a review a week ago, but he has cancelled because he's obviously not in pain, and I've said that's okay. He can have his further reviews with his dentist. So let's move on to another case. This is a full pulpotomy case. This was a 13-year-old patient. He presented with his general dentist, and you can see on this radiograph there's a large radiolucency on this lower left 7 here. His general dentist told him off that he had caries, started caries removal, and ended up with a pulp exposure. She did the same thing. She got a cotton pellet with some hypercal, popped it over the pulp, put a temporary restoration, and then referred him to me. You can see he's got immature root development. It's not fully developed yet. Ideally, we want to try and preserve that so we get continued root development. The diagnosis here, initially I thought this was caries, but I want to talk to you about it because it's quite an unusual diagnosis. This is something called pre-eruptive intracoronal resorption with secondary caries. So what is that? It's the very first time I'd heard of it. It was a colleague that actually told me about the diagnosis. So PEIR is a type of resorption. It's located in the coronal aspect of dentine, just below the enamel dentine junction of unerupted teeth. Either starts on the mesial aspect or the occlusal aspect. It's very often misdiagnosed as caries. And the way we know it's not caries is it's got a very large size compared to the time it's been erupted in the mouth. Now, if we look at the teeth for this patient, he's not got caries anywhere else. And suddenly this one lower 7 with an extensive radiolucency in caries. The prevalence is quite low, and most often it occurs in a single tooth. The most common tooth to be affected is the lower 7, followed by first molars, followed by premolars and canines, but extremely rare in those 2 teeth. We don't know what causes it, and it's not associated with any factors. Once you know the diagnosis, you will spot it in a few patients. So it's one of those things that once it comes to your attention, you see it more. The progression of it varies. So in some people, it's very slow, in some people, it's faster. Once the tooth erupts in the mouth, the resorption arrests. And that's because the vascular supply to the odontoclasts that are causing it comes from the dental follicle. So as the dental follicle breaks during eruption, the resorption will arrest. But you are left with this friable, necrotic, sort of decomposed material inside the resorptive area. And that's very likely to get secondary caries or for the coronal aspect of the tooth to fracture and obviously then end up with a problem. Now, what do we do? So if we find this in an unerupted tooth, we would normally just continue to monitor it. If it's very large, we may consider surgically exposing the tooth to arrest the resorption and then wait for it to erupt to definitively restore. If the tooth is erupted, like in this case, we can seal it with a sealant if it's small. If it's deeper, we're talking about restoration. And obviously, if it's close to pulp like ours, we may be talking about pulp capping, pulpotomy, or at worst, if the whole crown is destroyed, an extraction. So in this case, I said to the patient, obviously, we'll see what happens when we get in there, see how extensive it is, but let's try and preserve the pulp because we want to try and maintain root development here. I was not sure if this was a wisdom tooth, but in a 13-year-old, usually the wisdom teeth will be far more advanced. He had quite a strong gag reflex, so it was difficult to take any radiographs further back, but you can see on my follow-ups, actually, I don't think it is a canine. If it was, we may consider extraction of this tooth in a timely manner so that the wisdom tooth comes up. So when the dentist had first done the restoration, they weren't able to get a rubber dam on, and that's because the tooth had only partially erupted in the mouth. Now, when we do a pulpotomy type procedure or anything with the pulp, we have to use a rubber dam in order to prevent saliva getting in and obviously bacteria getting in. So the first thing I did was do an operculectomy. So just cut off this distal gingival area and then use a rubber dam. It was difficult to get a clamp on, but I managed it. So you can see here, this is after I'd removed the temporary restoration. We've got bleeding. The pulp is hyperemic and it's coming through that resorptive tissue. And we had caries. So first thing to do is remove the peripheral caries really well, because you don't want any of that being pushed into the pulp where bacteria can then get in. And you can see here, this is caries cleared and we've got a hyperemic pulp. Next thing I did was remove the pulp tissue. So we did a full pulpotomy. And then I tried to get hemostasis. So this is the cotton pellet and sodium hypochlorite once the pulpotomy had been done. And this is the pulp stumps after that cotton pellet was removed after a couple of minutes. And you can see that pulp looks nice and healthy. We've got hemostasis there. I then put Biodentine XP in the BioBulk full procedure into that pulp chamber and to replace some of the coronal dentine as well. And then we're doing, in an ideal world, what you would do is a self-etching adhesive over the biodentine, bond, composite, and then a composite restoration. And you can see this was the review radiograph. So this is post-operatively. This is at the 7-month review, and you can see we've got continued root development, and the patient was asymptomatic. And this is at the 1-year review, and again, we've got continued root development. I don't think this is wisdom tooth, as I talked about before, although we are going to carry on and just watch that area. Now, if you've done a full pulpotomy, don't expect to get a positive sensibility test at the review appointment, because you won't. So you just need to sort of carry on monitoring radiographically and with other clinical signs and symptoms. So in terms of Vital Pulp Therapy, our review protocol would be a 6-monthly clinical check with sensibility testing and radiographs. You do it at a year again, plus take a periapical radiograph. And if you're uncertain of the healing or the patient's remaining slightly asymptomatic, you can continue to monitor yearly for longer. Thank you very much. It's been a pleasure to talk to you this evening. I hope you enjoyed the webinar.
Welcome back, everyone. Thank you very much for joining us today. I hope you found the lecture insightful and engaging. We've received several questions throughout the session, and I have noted them as they came in. So let's start with the first one. So for you, Kreena, why not place GSC on the top of Biodentine? And the person who asked usually do that.
So I think, I know we covered a little bit about this during the webinar, but I think the main reason I don't like to use an intermediary GIC layer is because it adds additional time to your procedure, because now you're having to add a layer, wait for that to set, and then put another layer on. So one is time, cost of the material, although that doesn't bother me, but now you're having to, use another material on top of that. But I think the main thing is that it's unnecessary. We can make use of the Biodentine's properties. We know that Biodentine has similar physiomechanical properties to dentine, so we should be making use of this rather than adding all these layers in. And I think whenever you're adding more layers in, you are increasing the scope of error. So bonding problems, there's always a sort of a stage of error that could occur whenever you're introducing a new material. So to try and limit that, it's better just to use Biodentine as the full layer. I also feel like, when you are biting on the tooth and the forces are being transmitted, if you have less materials, the forces are always transmitted more favorably, rather than when you've got lots of little layers that they're being transmitted for. I'm very much a fan over the last couple of years of using Biodentine in this BioBulk manner, rather than these sandwich techniques, which I don't think work very well.
Thank you very much. I believe we have time for 2 more questions, maybe. So I see this one. How do you manage young patients when biodentine is setting?
I mean, that's always a little bit tricky, isn't it? Because it is a long set time. But I think the more you get used to using it, the more you develop a little protocol on what to tell patients. So I will always at the consult visit mention to mum and the young patient that this material does take a little while to set, and I will talk to them about the reasons that I'm using the material so they understand. Because I think when a patient understands something, it makes it a lot easier for them to cope with it and tolerate it. And I also think it gives mum time to prepare. So, for example, if I've used Biodentine and we're now waiting for the set time, I will normally tell patients, look, you can relax now, and I will sit them up a little bit usually. And that means that they're a little bit more relaxed rather than lying fully down. I will often tell mum to bring like some headphones if the child's a bit older and they can listen to some music or something like that. Or if the child's a bit younger, sometimes they can watch something on mum's phone just while they're waiting for that material to set. I will always keep an eye on them just to make sure the rubber dam's not leaking, but it just makes that time go a lot faster for the patient. Or they can like hold mum's hand when they're sitting up and things like that. So it just makes that process go a lot better. But it's really important to have a good rubber dam on to make that process less stressful, because if it's on, then you're not sort of holding them with trying not to get the material wet, and that's stressful having their mouth open. They can relax a little bit when it's doing it.
Super, thank you. And maybe very quick third question. Do you use the microscope for these kind of cases? I think we refer to the Vital Pulp Therapy cases.
Yeah, I do. I like using a microscope for all my cases, so I do, but I don't think it's always, it depends on what you have, and what you're used to. So I think you can treat these kind of cases very successfully with loupes, but I think if you can't see properly, then you can't treat properly. So it's important to, I think, to use some magnification to get the best results possible, but you don't have to. It's not, once you place the material, it's very easy to see what you're doing. But I think when you have magnification, you obviously perform the best.
Super. Thank you very much for that. So that's all we have time for today. A big thank you to our audience for attending and for the thoughtful question you submitted. And of course, thank you very much to Dr. Kreena Patel for the excellent presentation and for addressing the questions with such clarity. Before we close, a short survey will appear as you exit the webinar. Please take a moment to share your feedback. Your opinion is incredibly valuable to us as we continue to improve our webinars. And it's also meaningful to Dr. Patel, who dedicated her time and effort to be with us today. So thank you again and stay tuned for our next webinar. Thank you very much.
Thank you.